Hello, my name's Deborah Lupton and I'm Sharp Professor and leader of the Vitalities Lab at the University of New South Wales, Sydney, Australia. And today I'm going to talk about the topic of COVID life narratives using a sociomaterial approach. Sociomaterialism is underpinned by three major groups of theorists. The first are Indigenous and First Nations philosophies, which have been around for millennia. The second are a group of philosophers and scholars characterized by the work of Spinoza, Foucault, Latour, and Deleuze and Guattari. And then there's the third group, feminist new materialists, the work of Barad, Haraway, Braidotti, and Bennett. Key propositions from sociomaterialism. First, we can't understand human life worlds without acknowledging the role of sensory engagements, affective responses, and other living and non-living things. Humans are always part of more than human assemblages. These assemblages are dynamic, changing as people move through time and space. If you adopt a socio-material perspective on COVID research, these are the kinds of questions that you ask. What are the assemblages that are coming together? What are the key human and non-human agents involved? What affective forces, relational connections, and capacities are opened or closed by these gatherings? From a socio-material perspective, I use the term COVID assemblages to refer to the humans that are coming together with non-humans. First, we have the coronavirus, SARS-CoV-2, the novel coronavirus that is causing all this mayhem. Then we have the humans that the coronavirus infects, or the humans who try to avoid infection, and the humans who relate to each other and try to avoid infecting each other. Then we have other living things, including non-human animals that passed on the coronavirus originally to humans, believed to be bats, but also companion animals and the animals that people see when they go outside into natural environments such as their gardens or their parks or just walking along the street, and also the other living things such as plant life that they engage with when they walk outside the home and are in those kinds of environments. Then we have non-living things, places and spaces. So the place of the home, the place of the workplace, the hospital, the clinic, the leisure centre, the gym, the supermarket, the shopping centre. These are all key places where people move through or avoid going to, full of high touch points that people try to avoid touching or sanitize their hands after touching. And that brings me on to the topic of hygiene things such as hand sanitizers, but also, of course, face masks, soap, water, the everyday objects that people engage with as part of their hygiene measures to avoid the risk of infection from the coronavirus. Then we have language and discourse, and these have been really important in ways of conveying meaning of risk and COVID pandemic spread and restrictions and lockdown to people, particularly news reports, government officials giving press conferences, advertising, public health campaigns, interactions that people have with other people, chatting to them face to face or using digital technologies or smartphones. These are all ways that people learn about COVID and all ways that people seek to learn more about COVID and to avoid risk. Then we have the bodily sensations and affective forces that people feel in their bodies. So people often go through very different sensations as they walk between space and place, from one space to another. If they're in public, they're observing how other human bodies are interacting with theirs. They're attempting to engage in the physical distancing requirements that they've been asked to engage with, not to get too close to people, not to hug or touch people. They draw on how their body feels to decide whether they might be at risk of serious COVID infection or whether in fact they're not very vulnerable to risk. And also, of course, all the sort of emotional responses that people have, the anxiety, um, feelings of safety or danger, feelings of comfort or discomfort are all really important aspects of the COVID assemblage. And finally, people's memories and past experiences that come out of their biographies, their personal biographies. So what have been their previous experiences of pandemics or epidemics, of infectious disease? What has been their observations of how other people have lived through such epidemics or outbreaks? What have been their own experiences? Have they become seriously ill from an infectious disease before? Have they seen loved ones become ill and possibly die from previous infectious disease outbreaks such as seasonal flu? These are all really important in terms of how people come to understand COVID, how they live their everyday lives, and how they respond to the threat of COVID. The aim of the project, called Australians' Experiences of the COVID-19 Crisis, was to adopt a sociological perspective to identify how Australians from a diverse range of ages, geographical areas and social groups were experiencing the COVID-19 crisis during the first 6 months, including the first lockdown period. Project methods. We recruited our participants using advertising on Facebook, and Australians are actually very high and regular users of Facebook. 60% of the Australian population of all ages are Facebook users. So that means that even greater percentage of adult Australians are Facebook users, not including the child users, those under 18 years of age. This project was only for adults aged 18 and over. We conducted 40 semi-structured telephone interviews from the 21st of May to the 21st of July 2020. There were 19 women and 18 men involved, and there were 3 other people who were other gender identifying. We had an even mix of age groups from 18 years old right up to 76 years old. Our participants were spread across states and territories. They were spread across urban and regional and rural remote areas. They were evenly divided between those who were university educated and those who were not. 13 out of the 40 participants said that they were born overseas, which is actually very similar to the general Australian population because we have a very high immigrant population in Australia. 23 out of 40 reported a chronic health condition, and again this is quite similar. Statistics show that about half of all Australian adults report a chronic health condition. We asked the participants if they had tested positive to COVID. None had, but some said that they had friends or family members who had tested positive to COVID and had become ill. But these friends or family members actually were mostly not in Australia. They were overseas in countries such as the UK or the USA. 10 out of the 40 participants reported changes to work since COVID, and these included less work, so fewer shifts, for example, if they worked casual employment. Some people did have more work. Some people had become unemployed because actually quite a few people had become unemployed over the lockdown period. And some people found that their voluntary work ended. In terms of how we analysed the materials from the interviews, my colleague from the Centre for Social Research in Health, Sophie Lewis, did all the interviews by telephone. And after she finished each telephone interview, she made some field notes reflecting on the conversation that she had had with each individual participant. Then we recorded each telephone interview and sent the recordings to professional transcribers, and we were able to use the transcripts to construct, together with the field notes, to construct a very detailed case study for each participant. And I call these case studies COVID life narratives because they really do have quite a narrative flavour to them. They do talk about, each participant talks about how COVID has affected them over the time period of first hearing about the COVID crisis or COVID pandemic up until the point that the interview was conducted. So just to give you some sense of where the interviews fitted into the general conditions of the COVID lockdown and pandemic spread in Australia. This is just a timeline of COVID-19 as it was experienced in Australia, beginning from December 2019 to August 2020. So the first cases of what was then called the atypical viral pneumonia of unknown cause was reported at the very last day of 2019, and that is why it is called COVID-19. It wasn't until the 25th of January that the first Australian cases were reported, and they were incoming travellers from China. The 1st of March 2020, we had the first Australian death reported from COVID-19. Next day, we had the first Australian cases of community transmission reported. Then on the 11th of March, the World Health Organization officially declared COVID as a pandemic. So from mid-March until late March and into early April, a lot of things happened in Australia. The Australian government introduced measures to what they call slow the spread, including voluntary self-isolation of all arriving travellers, contact tracing, expansion of testing services. Then from mid to late March, that was when lockdown restrictions were progressively implemented by the Australian government, and national border control measures were introduced. Physical distancing rules were introduced. Non-essential services and many schools closed from late March. And as these lockdown and shutdown conditions began to be implemented, we did see significant reduction of cases in Australia from early April. And by the 30th of April, we had a total of 6,753 COVID-19 cases and 91 deaths reported in Australia. So we were continuing to see a steady decline in cases. Because the spread of the pandemic seemed to have been quite well managed in Australia, we began to see easing of lockdown restrictions gradually introduced across Australia from mid-May, and this was about the time that the interviews began for this project. Then, however, we did have some restrictions reinstated in the state of Victoria because we had a resurgence in that state in what seemed to be a second wave of infection. So about a month after that was when we completed the interviews for the project, and by the 26th of August we'd had just over 25,000 cases of COVID recorded in Australia, 549 deaths reported in Australia, and the global tally by this time was over 24 million confirmed cases, with almost 6 million in the USA alone and over 820,000 confirmed deaths globally. So this graph just shows how we did have quite a rapid rise in COVID cases in Australia. Then we began to see them fall significantly and quite quickly to very minimal levels, but then rise again with that resurgence in the state of Victoria. So I'm really interested as a sociologist in what everyday life in lockdown was like for Australians. And I actually took quite a few photographs myself to document what life in lockdown was like. So here's some examples of some of the photos I took. I took some photos of newspaper, articles and advertising. So we can see there all the government campaigns around how people should manage the spread of COVID, quite a few different measures that people were encouraged to do. There were lots of course, an abundance of news stories about the spread of the pandemic and the lockdown conditions and how they were affecting people. And then there were also advertising about businesses and what they needed to do to either stay open or open up again after the initial lockdown. Because I'm interested in place and space as part of COVID assemblages, I took lots of photos of the signs that were up in spaces where people were allowed to walk when they had their exercise. They were also told that they should physically distance even while out in large public spaces, in natural environments, for example. And of course, the environment of the supermarket changed quite dramatically, where we saw people rushing to buy products such as toilet paper and soaps, hand sanitizer. This is just an example of a local supermarket where the shelves of hand soaps and hand sanitizer were pretty depleted for quite a few weeks. Public transport and the kind of signage and instructions for people that were put on trains, for example, here in this is a photo from a train in Sydney. Then there were spaces such as gyms. This shows a gym where big squares were marked out on the floor, telling people where they could move and how far they could move in the gym, so as not to encroach on other people's space. We had an app called the COVID Safe app that we were encouraged to download and use, which was meant to help contact tracing. And then we were encouraged to keep supplies up of face masks if we had to go out in public where we couldn't physically distance, and sanitary wipes and hand soaps and toilet paper became stocked in people's houses as a sort of the emergency hygiene measures to protect against coronavirus spread. So in terms of the findings from the case studies that were constructed from these interviews for the project on Australians' experiences of COVID, here are some of the findings in terms of how people originally learnt about COVID-19. So quite a few people talked about Facebook and other forms of social media, but mostly Facebook, as the mode by which they'd first heard about the pandemic. In some cases, they were contacted by friends and told they needed to be careful because they were vulnerable to contracting COVID and getting a really bad case of it. Television news, of course, was also a dominant form of knowledge acquisition for people. And it was very, very common for people to say, at first it just seemed like a problem for China. It seemed like something very far away from Australia. Then, though, people did start to hear about perhaps people becoming diagnosed in their town or city or in their suburb, and they began to become worried about the risk to them of the virus. People did talk, particularly in the early months of the COVID pandemic, about obsessively checking online news reports for the latest updates. And also they noticed how people were behaving in place and space. So when people did go out of their homes, they did often notice whether other people in the public spaces were behaving cautiously, or in some cases getting too close and maybe making people feel vulnerable. So that was observations of other people's behaviours was also an important part of how people learned about the risk and how at risk they felt themselves from COVID-19. So just to get back to people's initial concepts of risk, these are direct quotes from the interviews. I remember feeling like it was a distant concern. That just gets back to the fact that originally people did hear about this new coronavirus outbreak in China, and it really did seem like it never was going to be a problem for Australia in the first few weeks of the pandemic. Then people did often mention, when they talked about previous highly publicised outbreaks of infectious diseases, such as SARS and MERS, and here's a quote here: "I thought it was an overreaction because SARS and MERS turned out to be not as big of a thing as people were worried about." So people did remember when there was quite a lot of news coverage about those kinds of outbreaks, but it never ended up being a problem in Australia. No one in Australia became infected with those coronaviruses from previous pandemics. And so the mindset was, I was thinking, oh, it will just be another one of those things that won't really get into this country. Again, remembering back to previous outbreaks. Or people compared it to seasonal flu. I just dismissed it all as just another flu. I thought some people die from flu and it won't be me. So people are aware that seasonal flu can be quite deadly. Usually in Australia, between 2,500 and 3,000 people die each year from seasonal flu. And people are aware of that, but it hadn't affected them thus far, so they didn't think that this new pandemic would affect them. Now, there were key points when risk became real for people, and some of these I've already mentioned, but just to go over this again. One example is when the World Health Organization finally announced that COVID-19 was a pandemic. That made people realize, yes, this is a serious outbreak. Other people talked about when my doctor warned me to be careful because they had a pre-existing condition or were elderly and therefore were considered by the doctor to be at high risk of contracting the coronavirus and becoming seriously ill from it. Other people talked about hearing in the media that people like me were vulnerable. This gets back again to certain social groups being identified, particularly older people or people with pre-existing conditions being identified as particularly at risk. For other people, it was when the shutdowns and restrictions started in Australia because they were very stringent shutdowns and restrictions. Many businesses closed down. Most people were forced to work from home. Schools were shut down. Children had to learn from home. And so it really did upend everyday life for people. And that's when a lot of people did realise, hey, this is serious. If this is happening in Australia now, this must really be a serious pandemic. Other people talked about when I noticed that the case numbers and deaths were rising rapidly in Australia. So in Australia as elsewhere, we'd had daily case counts and death counts, and we still have those each day reported by each of the states and territories in Australia. And it did reach a certain point for some people where they did see how rapidly rising these statistics were. Then there was a very controversial issue where a cruise ship called the Ruby Princess docked in Sydney as it had arranged to dock, but people were let off the ship, which had thousands of people on it, passengers on it and staff, without being tested for COVID, and it turned out later that quite a few of them did have COVID-19 and in fact went on to travel to other parts of Australia and to infect other people. So that was actually a really bad lapse on the part of both the federal government authority and state New South Wales authority in Sydney to not control the movements of those cruise ship passengers. So bringing together all of these elements in terms of how people talked about how they learnt about risk and how they came to see that the COVID risk might be an issue for them. These are the elements, and I'm calling it COVID risk assemblages, getting back to this socio-material approach, which recognises that risk itself and people's understandings of risk are more than human. They include not only humans, but other than human elements. So first we have location. I definitely found in the interviews that people who lived in rural and remote communities felt much safer from COVID. One reason for this is that they didn't really have many people in the area, if any people at all, who they'd heard about who had COVID-19, and so they thought that they themselves quite rationally wouldn't be at risk because very few other people in their community had it. And they very much felt as if they were kind of isolated from the main centres of COVID outbreaks, which were, in most cases, major cities in Australia. I also found that people very much liked the fact that their state governments had closed borders between the different states of Australia. That made them feel safer, that there weren't people coming in from other states into their state. So there was a bit of a sort of regionalism going on there in terms of wanting to protect not only their local region, but also the whole state from being contaminated by the viral infection. Then there were news, social media coverage, very important how people first learned about COVID risk, but also for some people, hearing certain news items made them really feel as if they had now become at risk themselves. There were the statistics, infection and death numbers. There was the assessment of government's responses. Most people were very positive about their state government response to COVID, as I said, including the closing of borders, but they were less positive about the federal government response. Then there was people's own health status, so how they felt themselves in terms of their physical vulnerability, whether they identified as one of the at-risk people from infection and significant health effects from COVID-19, whether they had an underlying condition, whether they were older, whether they were having treatment for cancer. All those issues did, of course, have a major role to play in how much people felt personally at risk from COVID infection. There were the previous outbreaks that people talked about, flu outbreaks, other pandemics worldwide, and whether or not people felt they had had effect in Australia. It was interesting also that the last significant pandemic we had in Australia was the so-called swine flu, the H1N1 pandemic, which did affect Australia, and people did become ill from it, and we did have some deaths from it back in 2009, and there was lots of government campaigns about how to protect oneself against this H1N1 pandemic influenza. But in the end, it fizzled out in Australia, and not many people, as thought, became ill from H1N1 or died from H1N1. And in fact, a vaccine was introduced very quickly, and so a major vaccination program came into place to protect people. And it's interesting that very few, only 1 or 2 people even mentioned that previous pandemic, which was the last big pandemic in Australia. It just had they'd completely forgotten about it. It wasn't in their horizon. It didn't have any influence about the way that they thought the COVID pandemic would play out. And then, of course, other people's behaviour, as I've talked about, noticing other people's behaviour in public spaces, whether feeling vulnerable because people were coming too close or didn't seem to be coughing into their elbow as they should be, and all those sorts of practices that we have been warned in Australia not to do, observing if other people are either upholding those practices or not upholding those practices was a significant contributor to people's understandings of their personal risk from COVID. So in terms of how lockdown changed people's lives, these were the main practices and experiences that people talked about. People talked about being really worried about their family members, particularly their elderly family members, and particularly those members that they couldn't see in person anymore during the lockdown period. People were worried if they'd lost their job, about how they would find a new job. Quite a few people talked about exacerbation of their mental health, pre-existing mental health conditions. Other people talked about how they'd been seeing more of their neighbours because they no longer could rely on seeing people who lived a fair distance away from their home. They were confined to their homes during lockdown for the most part, and they took the time to actually spend more time with people living very close to them, such as their neighbours or people who lived in the apartment block that they lived in. People did miss regular activities such as going to the gym or having dinners with friends. There were other issues around not getting the medical care they needed because the healthcare system during the first lockdown period was very much oriented towards dealing with COVID patients and COVID testing. So elective surgery was put on hold, and a lot of people actually did put off going to see the doctor for other conditions because they were worried about becoming infected, or they thought that they didn't want to burden the system in this case where they thought there might be a need for better attention to be placed on COVID patients, so they avoided going to get medical attention for other issues. Quite a few people talked about disruption to their sleeping habits. Either they started sleeping during the day because their routines had been completely lost and they had nothing to get up for, or they had trouble sleeping at night because they were feeling worried about the situation and what was going to happen in Australia in terms of the COVID crisis. Many people did start contacting people outside their household more than they usually did in the past using the phone. Video calling became very popular across all age groups. And watching streaming services such as Netflix became a very popular pastime. So just to finish, here are some open access resources that people might like to pursue if you're interested in learning more about how to do fieldwork in a pandemic. If your approach usually involved face-to-face interviews or focus groups, or actually going out and doing participant observation or other forms of ethnographic work, being in the same space as people, I put together a crowdsourced document that has a very extensive list of alternative ways to go about doing field work in conditions where you can't actually be in the same space as your participants. Also, I've put together a short form webinar series on YouTube called Breaking Methods, and this is all about introducing innovative methods for how to do social research, not necessarily social research that has to be physically distanced, but it's just another way of helping people who might be interested in accessing research methods in situations where we can no longer run hands-on workshops. So if you're interested in checking out some of these methods, there's some really interesting examples from myself and members of my Vitalities Lab, such as the storyboarding method, scene making, researching TikTok, digital diaries. We have quite a few different approaches that we're explaining on this webinar series, so you may well find it interesting. Thanks very much.